This is Dr. Eril. I'll be the moderator for today's session. Today we have a very interesting topic. We're going to take the perspectives of some of the world's renowned key opinion leaders. And gentlemen, thank you very much for joining us. So briefly, I would like to introduce Professor Malhotra on my right. Professor Malhotra is a very renowned person. He is the president of Federation of Obstetrics Gynecology Society of India. He is also the president of Federation of Obstetrics Gynecology, Southeast Asia and South Asia. A very renowned person, professor, teacher, researcher, and currently the managing director of Rainbow Hospital Agra. And I have Professor Yadnik here. Professor Yadnik is again a globally recognized person. In fact, you just have to Google out and know about him a lot. He is the head of the department of King Edward Memorial Hospital, Pune, and he visits a number of universities across the globe. One of the universities where he teaches molecular medicine is University of Exeter, UK. And he is also a visiting professor, the Danish Diabetes Academy. Today, we have two of our panelists who are rated amongst the top in the world, Stanford ratings for the quality of publication and for citation of publication in the field of diabetes and nutrition. None other than Professor Mohan and Professor Yadnik. Both are here, and we are very happy to have such a discussion and to get their perspective of the nutraceutical industry and overall the nutrition as a way forward for the way of life. With that note, thank you very much. We get started. I would ask a question to Professor Malhotra. Professor Malhotra, how do you look at products that are promoted in the Nutra segment to you?
So, a very greetings to all. What nutraceuticals has become is what we call it now medical food. So, we had pills, we had syrups, we had injections. Now it is the food which is going to be your medicine. And I remember I always give a punchline: eat food as a medicine. Otherwise, you will have to eat medicine as food for your lifelong. So that is what is the change is coming to nutraceuticals. And we all are Indians, especially as you heard, we all have a lot of in fat. Even with low BMI, the fat is more, and we are all prone to metabolic syndrome diseases. And metabolic syndrome, for the general people, they can just evaluate themselves. Your pulse should be less than 80, your fasting blood glucose less than 80. Rule of 80 is what we call. Your waist circumference 80, and your triglycerides 80 into 2 less than 160. Your good cholesterol HDL 80 divided by 2, 40. And so that is what, or 80 kilos of weight for a 6 feet. So that is what should be. Now this is not possible by the diet we eat.
Right.
So either you modify your food and have correct eating, or you add supplements. And the supplements which we use especially for women's health, because Indian women are more prone to metabolic syndromes, is that you need to add all the herbal products. Because there is a big now hue and cry, or what we say, acceptance towards herbal products. They feel herbal products are good, they don't have side effects. So even flour like this, what we have, this is also eaten. So this is put on desserts, which I've seen. So we have all these.
Great points, sir.
So nutraceuticals made out of plants is what we are promoting. Coriander, Satavari, Ashwagandha, a lot lutins, and so there's so many of them, and that is what the future will be.
Fantastic. That's Professor Malhotra's views. Wonderful, sir. You are again a great thought leader. And what are your thoughts, sir, on this?
Thank you. He's described it so well for diabetes and nutrition. I'll concentrate on one micronutrient with which I'm very fascinated, and that's vitamin B12.
Your life's passion.
Yes, my passion, yes. So when I was a student, I was taught that vitamin B12 deficiency is related to pernicious anemia. And that means you can't absorb it, you have to take an injection and you will be all right. So research after that has shown that Indians have perhaps the largest B12 deficiency in the world. So we can be one more capital on B12 deficiency. And why is it so? Because we are vegetarian and B12 in food comes only from non-vegetarian foods. Now where do the non-vegetarian animals get it from? The ultimate source in the world of B12 is microbes. Only microbes can synthesize it. Then it enters the food chain through the animals which eat microbes, and as human beings we get it from animal products. So meat, liver, eggs and other products. For vegetarians who are a bit broad-minded, they take it from milk. So that is how B12 enters human body. India, as I said, has B12 deficiency not because of pernicious anemia, that's absorption defect, but because there is less B12 in the food.
Okay,
so our nutrient intake is low.
So vegans stand a very poor chance.
Exactly. Vegans especially need to take B12 supplements. And if you want to do it for millions of people in the community, we cannot increase the non-vegetarian food for those who are vegetarians for religious and cultural and ethical reasons.
Right.
So you have to give some supplements. So you choose foods which are acceptable, so milk and milk products, or fortify foods which they usually eat, or use nutraceuticals through various routes, either through milk, yogurt, Nutra bars, or whatever things we can think of. Today we had beautiful exposition how 10 different routes can be used to improve your nutrition.
Right.
Because I want to introduce one more word. For micronutrient deficiencies during our training, they were gross. So we had beriberi, we had rickets, we had whatever, scurvy. Today that level of deficiency is gone, and what we have is called hunger or the hidden hunger. So it's the hidden hunger epidemic which affects large number of people. Deficiencies are relatively mild considered to the extreme syndromes, and therefore we need a large input into the community through various sources, and what better than targeting different nutrients.
Oh, great point.
So we'll be fortifying food with practically everything. Iron, iodine, B12. So your atta is on your rice is going to have everything.
So
or your salt.
atta, salt,
That
and
is
then
because
milk.
what you eat every day can be
Yes,
fortified
exactly.
Create a holistic
rather than
food.
giving them as pills
Exactly.
or syrups. The
And
food
that's
is
what we have investigated over
medical
last
food.
10 years. Nutra bars,
so
yogurt,
that's medical food.
Yeah.
Holistic food.
And your chocolate bars could be just
Exactly.
fortified. That will be the best.
So you make sure that they are given B12 and other micronutrients through something which everyone eats at different times of
And
the day.
probiotics.
Great.
Probably. Because
That's
you said the good bacteria
micro.
inside
Exactly.
us keeps us healthy.
So we need to find out probiotics which will make B12, because some probiotics use B12.
I know.
So then there is a problem. So that's why we need more research. Yeah.
Great, sir.
Thanks.
Wonderful insight. I think that brought us a lot of new information to all of us to the table to discuss about. I mean, on one side you touched about the lack of certain things. We are still a highly iron deficient country, and he talked about the B12 deficiency, the hidden hunger. Hidden hunger is a wonderful concept, sir.
Yeah, I know. Yes.
Lovely that you brought this up, and I think we really need to look at holistic food, a food that would really balance out properly. So I would rather like to move on to another question, sir. Another important question, which I think the audience are interested to know from each of you, right? From your personal experience, you can tell us your experience of some ingredients, and what have you, how you have researched, what you have studied, and what do you teach What do you want us to know from the nutrition point of view?
So very, very, very important. As being a gynecologist, obstetrician, dealing with two lives, a pregnant woman and the child inside, my first talking about nutraceuticals from womb to tomb. So there is a different need for women at
That's
every
a very favorite
yeah, that's my
creation.
And another favorite thing is when the girl becomes teenage, because see, our adult diseases are programmed inside when you are in the womb. And if the mother is not taking the right supplements or nutraceuticals, especially folic acid and things like that. So we concentrate on folic acid. Let's see. So folic acid, how every from teenage to menopause, every woman should take a tablet. It's the cheapest nutraceutical available intervention, and it takes. So when I was the president of the Foxy, then we ran a campaign on folic acid, and what we said, call it the engagement pill. So the girl gets engaged,
So
give her a
preconception.
packet of folic acid.
Wow. Okay.
So don't give her any other present, give her a big box of folic acid
That's
for a
wonderful.
one year supply, because
Okay.
mostly couples produce a baby within a year. So 1 year she's taking
Watch
folic
out, guys, even this is what you need to present
so
to.
that's
Girls.
what was.
Right.
Then of course for polycystic ovarian disease you have inositol, and now we have capsules, tablets. But see, again, it is not being given in the right amount.
Right.
So myo-inositol 4 grams you need, and the studies have gone up to 18 grams, and up to 12 it shows no side effects, or no, up to 12 can be given to any prep. It can, why use it only in PCO? It can be used for pre-diabetic, diabetics, all over, and a combination of myo and D-chiro. By the way, I think myo-inositol was called vitamin B12, 8 first. Then they proved it was not,
Inositol. No.
it's no
Inositol.
longer vitamin
Yes.
B8.
Yeah.
It is a kind of sugar,
Correct.
and it prevents insulin sensitization of the cell, because our body cells need glucose to function, and if they are resistant to insulin, the insulin will not go in the cell and they will not function. So you need some products which will be insulin sensitizers. So that there is where this inositols will work, and it will work in menopause also. Mood changes, dullness, hot flashes. Add it with phytoestrogens. You are scared of giving estrogens because of cancer risk and all. So isoflavones and mixture. So that is another area which we have worked. And of course, fertility foods for men and for women. So the nutraceutical in human life is at all stages and different.
Fantastic. I mean, would you like to add any points on how this generation of data on, let us say, on this value of myo-inositol in the Indian context and things?
So now we finally have some studies coming in, and in fact, our association also started a multicentric study on clinical evaluations, because the other studies have to be blinded, double blinded, compared with drugs like metformin or anything for polycystic ovarian disease, or with other insulin sensitizers. So we could do a good multicentric study comparing head to head 4 or 5 drugs, or better, easiest is a clinical trial which we do. And clinical trials, when we do give it to the girls who are androgenic, acne, hair loss, hair fall, stria, getting obese, having blood sugars high, having insulin levels high. So there you can monitor these levels and come to a conclusion. So some studies are showing that it is quite favorable, and
Great.
I think we still need a big before the world recognizes.
We should do that.
Yeah, because you see turmeric,
Absolutely.
Indian product, but
Right.
patented in America.
Absolutely.
So
Absolutely.
we didn't do any clinical
didn't do
studies, or we didn't say do that.
didn't,
So we
yeah.
need to do some our own studies.
I think that's a point too. Very nice, sir. Thank you. Thank you. I think that's something, a great take-home message. So from your perspective, you have been a passionate person who has been working on nutrition from ever since I know, many decades. So, I mean, in the sense, you don't have to be curtailed with 1 or 2, you could talk about it. And I just would like to request you, you have been in the panel of Indian Council of Medical Research, so you could also tell us something about that.
Right.
After you finish on the
Yeah,
micronutrients.
okay. Thank you. I mean, thank you for taking
Sure.
me back in the history.
Right, sir.
And I started my career in 1980s with investigation, like Mohan did actually, investigating a condition where diabetes is associated or occurs in malnourished people. So that was the concept that time, malnutrition related diabetes. And broadly it was divided into those who have pancreatic problem, that is calculi, and those who don't have pancreatic problem. Now that time we were weaned on this terminology and both of us decided to look at it.
Oh.
Mohan published on pancreatic
Fantastic.
calcification, I also published, and what we found was that the studies were limited to cross-sectional studies. They were looking at patients who were coming to the clinic, and diabetes as a disease is considered a disease of overnutrition. So you expect patients to be centrally obese, generally obese, etc. These were the patients who stood out because they were undernourished, and the term malnutrition related diabetes came. We investigated and realized that we need actually to go backwards in time to see whether malnutrition had contributed to diabetes or uncontrolled diabetes had contributed to malnutrition.
The other way around.
The classic problem of cross-sectional studies,
Yeah.
you cannot decide the causality, and reverse causality is a possibility. Within 5 years of me starting my research, I was just quite, like say, fortunate to meet two people. One was Norbert Frankel from US, who developed the concept of programming of the fetus by maternal diabetes and metabolism. That was from the side of overnutrition. I met David Barker, February 1991, and in 15 minutes, he converted me into a Barkerologist.
Barker's theory is like,
Yeah.
it sounds good.
So February 1991, David Barker comes and meets me in KM Hospital, Pune, and he shows me slides from his paper which was going to be published in BMJ in 2 months' time. And what did that paper say? Lower the birth weight, higher is the risk of diabetes. Now,
This is a message that has to
Yeah.
go. Lower the birth weight.
higher is the risk of diabetes.
what we call is
Higher is the
dual
risk of-
teratogenicity.
Yeah.
Underweight also causing problem, overweight also causing problem.
Yes.
So dual teratogenicity is the word.
Yes, dual teratogenesis is Yadnik's term. I published it in
You
International
are the
Journal
person
of
who coined
Obesity
the
and
term.
Gynecology.
Wow.
When they invited us to to actually interact with a caucus.
Is there any cutoff? Is there any value which becomes, a diabetogenic?
I'll tell you.
cutoff
I'll
point?
tell you. Okay, the associations in biology are usually U-shaped. So less of
Yeah,
something
agreed.
and more of the same
Yes.
thing cause similar problems. And depending on the population's history, that moves here and there. And therefore, it's impossible to give a cut point. It's a continuous association, but it is either progressively increasing or decreasing in that much segment. And that's what I wrote. It was International Journal of Obesity and Gynecology.
Okay.
So, Norbert Frankel teaching me larger birth weight in a diabetic pregnancy increases diabetes risk. David Barker teaching me that lower birth weight in undernourished mother
Will also cause
causes problem. Now we have added the aspect of micronutrient undernutrition even in the obese pregnancies, the hidden hunger. So from both the sides there is undernutrition component which is obvious or not obvious with an overnutrition component, and that has driven all our research.
So incompleteness of food or
So it's either like say your personal habits, likings and dislikes, that is at the central individual level. Then you go to family, family will have certain dietary habits.
correct.
Then you go outside, there's religion and culture.
Correct.
So if I am actually a religion which believes in not killing the animals, then I am a vegetarian.
Yeah.
And in India, this started 2500 years ago with Samrat Ashoka becoming Buddha's disciple. after the Kalinga War. And Buddha taught him ahimsa. Ahimsa not towards human beings but also
towards
towards
animals.
animals.
Jiva
So
Karunya.
Indian vegetarianism is multi-generational, unlike the Western
Right.
who are now doing it for ethical reasons or because of climate change and the energy requirements of growing the buffaloes. We had it in sort of imprinted in our culture for more than 2,500
I think
years.
this is one point yourself and Professor Mohan
Yeah.
can rather. On one side, we are talking about the issues of, you know, eating, overeating, and incompleteness of food, or habits, and let us say non-violent way of thinking. But at the same time, B12 deficiency, all that emanating because you don't eat certain things.
Correct.
How do we?
So I'll tell you, Professor Mehrotra said that we should eat folic acid, and they give a lot of folic acid for various reasons. And there is a beautiful imbalance between B12 and folate, which is generated partly by iatrogenic reasons and largely by natural reasons. So in vegetarians, B12 intake is low, so there is B12 deficiency. Folate intake is good because they eat vegetables, so folic acid comes from foliage. So that comes in. So in our studies, we have found very little folate deficiency in our population. I'm not saying it's not there in India, it's there in certain populations, especially coastal non-vegetarian eaters. Their folic acid is actually, or folate, sorry, is more deficient. Now what we showed is that in our studies of birth cohort, mothers with low B12 but high folate levels, which partly came from their diet and largely from use of large doses of folic acid, which obstetricians are very fond of prescribing.
Okay.
They prescribe it largely to prevent neural tube defects.
Right.
So it's used for fetal defects.
Correct. So neural tube defects happen very early in pregnancy, before 28 weeks of gestation. A woman doesn't come to you usually in that period. So either it has to be preconceptional or it has happened or not happened. But they give large dose folic acid. The tablet in India is called Folvite.
Yeah.
It is 5 milligrams. That is 5,000 micrograms. The preventive dose for neural tube defect is 400 micrograms. So each tablet is 12 times higher than what it is.
So there is a large iatrogenic
Iatrogenic component.
okay.
In a B12 deficient population, we give too much folic acid.
I think Nutra industry has to take this.
This is a very important.
That is what, for all 3 trimesters, you have to define a different nutraceutical.
Fantastic.
First 3 months is folic acid is more, then the folic acid goes out, and then the DHA comes for brain and iron, calcium, magnesium, zinc supplement, and lastly again magnesium and zinc to prevent preeclampsia, blood pressure, GDM.
Right.
So you need to differentiate, not prescribe the same tablet for 9 months.
See,
Really
this
great.
Norbert
I think,
Frankel again beautifully defined that early pregnancy is embryogenic,
Yes,
middle is neurogenic,
neurogenic,
and last trimester
weight
is
and-
anthropometry and metabolism.
weight and metabolism.
So we
Great
have to
points.
actually
Great
do
points.
that.
So can I move on to the another one
Yeah.
important point, which again the Nutra guys who are sitting here or who are listening to us are interested to know, is that we do have a lot of herbals in Indian context, Professor Malhotra, and you are a good proponent of using herbal products. In India, we have the Ayurveda, Siddha, Unani, and all various kinds of the traditional medicines, Indian traditional medicines. From a Western point of view, you could say that they are phytocompounds or phytomedicines. There are also questions about their safety, right? There is one kind of a belief that all these things are traditional, therefore there are no side effects. And there is another school of thought is that there is an incidence of hepatic toxicity, there is renal toxicity.
Renal toxicity.
So,
renal failure.
how do you look at that, sir?
So first thing we have to understand, why are we giving phytonutrients? So phytonutrients, phytomedicine, phytonutraceutical, whatever you want to call it. Because the plant source long back, you go to Mahabharata for healing, Lakshman got hit by, he almost died, and the Jadi Booty was brought from the Himalayas and that healed him. Right. So there is some truth that, and a lot of, even the pharmaceutical industries use a lot of plant products to make allopathic medicines and all. So the problem with Ayurvedic, probably what I think is when they add metals to it. So gold bhasam, silver bhasam, copper bhasam. So when you add metals, and if it is overconsumed, our body is not going to excrete metals. So that will of course probably harm the liver, and so that's where probably the side. But if it's a well-crafted, well-studied nutraceutical, then it will take care of a lot of oxidative stress, the free radicals which we produce. Every day in our life is stress, even sunlight is a stress, the skin aging causes aging because of the ultraviolet, so we need sunscreens, we need things like that. Our chromosomes have telomeres, we don't eat properly, the telomeres get shortened, so we age very fast and the whole body gets wastage. And so carotenoids, flavonoids.
You feel that Ayurveda is something that is evolving, and
it should be researched and well published. And some of the big Ayurveda companies which advertise so much now, and unfortunately they're not here, should have been here. We should have called Ramdev to talk here. So he claims that he has got scientific basis, papers supporting it. Yes, maybe he has.
Possibly,
but for lactational, for women who are lactating, Shatavari and all have proved to be great. All the pharma industries are now producing lactagogues based on herbal therapy. Even for menopause, isoflavone soya food is
carrying out safety studies are
very important.
Right?
Though usually it's overeating. You go and eat a whole tree of leaves, you will get upset. So it's like the right amount. So the dose titration.
That's a good point, sir. I mean, we don't have dose ranging studies, safety studies. In the sense we do have, but not the kind of studies that you publish in Lancet or BMJ but we do have some studies here and there. So, from your researcher perspective, clinician researcher, which is very rare and top of the pyramid, clinician and researcher, what do you think about the safety and the dose ranging requirements of herbal products?
Right. Let me say, I don't know whether this term exists, but there should be nutri-vigilance.
Okay. Yeah, I think the term is coming in.
Nutraceutical, maybe it's there. I just
we
thought of
are
it.
pioneering that here, certainly.
So nutri-vigilance is required.
Very nice.
So you need to really follow them by the current guidelines for following the toxic effects of the drugs. Second is, of course, nutrigenomics. Okay, the individual is going to respond depending on his genetic.
I'm going to come to this topic again.
Okay, and epigenetic background. And we can see that we have recently published last month in Lancet how the genetics of type 2 diabetes is different in Indians compared to Swedish. And then we also describe 4 subtypes of diabetes which are genetically also different amongst themselves.
Do you think herbs have any effect useful?
So naturally, when they are exposed to something, this is going to play into it. Whether it will have a major effect or not, we won't know unless we study it. Now also we go by, like say, many times stories which have been written, and for many years spirulina was actually a very popular source because they said it contains B12 and it contains omega-3. As time went, the effect on B12 was not as expected. And then came out the investigation that spirulina contains pseudocobalamins.
Oh.
So false B12.
False B12. So looks like B12 but is modified in some ways so that it competes with the natural B12 and therefore might even reduce the action.
Oh my God.
And therefore we have now gone to another algae. And why algae? Algae are vegetables.
Is this published, sir? This data is published?
Oh yeah,
Yes,
it's
it
quite
is
widely
published.
known.
Okay, quite right.
And therefore we are now investigating, we have done the pilot trial of an algae called chlorella.
Okay.
Now why am I interested in algae? Vegetarians
France
will
also.
take it without any problem, and therefore we are concentrating on nutraceuticals coming from vegetarian world. Otherwise, otherwise the plants do not have
produce
B12.
Okay.
But these algae acquire it from symbiont bacteria.
Your views overall on the nutraceuticals, the data that is available, are you okay? Are you happy with the data that is there? Are you still not very comfortable? What are the discomfort areas? Something on that side. It may be a little bit broad, but I'm talking specifically, you get data on an estrogen data, right? A conjugated estrogen data. And that data versus myoinositol data, are you happy? So
the data has just started coming in, and I'll ask you all to Google. So you Google phytoestrogen, you Google estrogen. When you Google estrogen, you get scientific data. When you Google phytoestrogen, you get a whole lot of products there. This is soya based, this is with isoflavine, guaranteed to remove hot flushes, guaranteed to, and you get very less scientific data. So with nutraceuticals, what we are getting is the data is full. Google will give you 1 million responses.
quantity is excellent.
Yeah, but the real science is not lacking yet.
The depth.
So while a pharmaceutical cannot release a drug without scientific data, with a phase 1 trial, phase 2 trial, phase 3. Here there are no trials. It is a food product. It is registered as
that's
a
a point
food
for the
or
nutrient.
FCCI. What they said that you can register like anything under that and give anything with any amount.
Does it put you in the discomfort while prescribing?
Absolutely yes. When I want to give myoinositol to a patient in the dose of 4 grams, and when I look at all the things available, one single capsule, someone has 10, some has 20, some that leptin or whatever that anti-aging, you need 100 milligram of it, but most of the capsules here only have 10. So 10 capsules a day, how are you going to eat? So it has to be put scientifically. What that 10 is just for the name, and the cost has gone up because they put 10 things, 10 very exotic micronutrients and this thing in that same capsule or a small sachet, and the price has gone too up. So I'm not happy with that area. So I think we need some scientific data, and especially with drugs like ionositol, which could help a lot of diabetic, as being the diabetic capital of the world. And even for menopausal women, all of us are growing older age, and even some drugs or herbal drugs which will have transgenerational
issues.
2 generations before, if they took something that may show up in this generation.
Okay.
That's where the nutrogenomic study comes.
Yeah, right.
So the genes are there.
I'm going to go to
The genes are there, but the epigenetic might have
Thank
disturbed my great grandfather's
Yeah.
this thing, and that has come to me.
Sure.
So that I'm very scared of.
Great.
I don't know. You
So-
will tell us more about it.
I'm going to rush to Professor Yadnik on this point. So, on one side is, are you okay with this data that is all getting generated? At the moment, the nutra industry is in a crossroad kind of a situation. They don't get the kind of intellectual property protection for everything. So, the money invested to generate data is quite huge to do a clinical of a standard of, let us say, an atorvastatin or a rosuvastatin. Not going to happen that way in this industry because the IP is very weak.
Yeah.
Intellectual property is weak. So there is a limitation in terms of investing money in clinical development. So there is sometimes, there is a kind of a compromised data that comes in. So how do you look at that, number one? And what are your thoughts? I mean, how do you advise us to navigate this situation?
I think this
From
is
a scientific perspective.
Yeah, so this is where the ethics of science comes in.
Absolutely.
And we know, first do no harm.
Yeah. right.
So that should be the driving principle.
Absolutely.
Safety should be guaranteed, and for which I think there is no option
Absolutely.
but to have a scientific data. It may be preclinical. Now, of course, science has advised so much that instead of animals, we can even do it in cell cultures or model it or whatever. So we need to go to the modern methods of proving that this is unlikely to be dangerous.
That will make it faster also.
It will make
rather
it
than
faster.
putting in an animal
Quite-
and letting
quite
that animal.
right.
Got it.
Yeah.
Got it, sir. I think we have spoken this, so we have re-emphasized it. I would also now quickly add, I would like you to discuss on the nutrigenomics. It's every
Right.
we
So-
really don't know much. I mean, the
Yes.
sense here and there, that Google we can always learn.
Right.
But for the audience, would be
So let me take an example of the paper we published last month. It's based on comparing the type of diabetes in India and Sweden
Okay.
for those who are diagnosed before 45 years of age. Now, if you go to any meeting like say ADA or ESD, the stress is that young people get diabetes only if they are obese. And the whole treatment is planned to reduce insulin resistance, which is associated with obesity. Now, over years, our seniors, including Dr. Vishwanathan, Dr. Ahuja, Dr. Tripathi, have all stressed
Previous
that we have less BMI in our diabetic patients. I capitalized on that and described the thin fat concept. Now, if we compare the subtypes of young diabetes in Indians and Swedish, what we find is in India up to 60% are severely insulin deficient diabetes who are not overweight. In Sweden, 66% of diabetes are overweight, obese and insulin resistant, diametrically opposite conditions.
So deficiency and resistance.
Yeah, correct.
Right.
And we are using same guidelines given either by ADA or ESD or IDF, where the first line of drug is metformin because it controls insulin resistance. So there's a time to wake up, and we need to actually investigate, which is what we are now planning to do. There it's easy because the guidelines are laid down. We'll need a randomized control trial with crossover,
Correct.
etc.,
Right.
etc. Here we need to be aware. We can also learn from our past experience that certain products might have actually reacted in certain populations, which we should not ignore. And we should be aware that Indian genetics and epigenetics is different. A lot has been generated about this in last 20 years from Indian genetic studies.
How does it apply to a day-to-day practice?
So one like say MTHFR,
Okay.
you measure it commonly. It is supposed to be one
Because
of
you
the-
measure this common.
Because folic acid
Yeah,
deficiency.
folic
right, right.
acid. So
Folic
it
acid
is an enzyme involved in folic acid or folate
Converts folic acid
metabolism.
into
Right.
methyl
Yeah.
folic acid. So
And therefore it goes into DNA pathway. Now Western people have a allele frequency of that particular MTHFR called 677C to T to an extent of 20-30%.
So that's feasible. I mean,
So it's quite common there. Therefore, their whole attraction is there. In India, especially in South India, the allele frequency is less than 5%.
okay.
And in North India, about 10-12%. So we are very different.
Excellent.
And therefore, we
So
have
we're
to
genetically
take
different.
that into
And then the
Excellent.
epigenetics disturbs the whole thing. The bad genes get, so Indian, the epigenetics, the bad genes get activated much.
Okay. So I think at the end of the day, I mean, the key take-home message is there is a great requirement. There is a great understanding of the necessity, but at the same time, there are certain areas where the industry has to come up to the standards in terms of clinical evidences, safety data, efficacy data, and dose, proper dose collections, and perhaps utilization, daily utilization of modern methods like nutrigenomics, and bring in more vigilance into what we take. I think it's been wonderful, gentlemen, having both of you here.
Thank you.
Thank you so much.
Thank
Thank
you.
you.
It's been
Thank you.
wonderful.
Thank you.
Thank you very much.
Thank you.